Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. I'm your host, Dr. Jessica Schwartz, and I'm thrilled to have Dr. Michael Furtado with us today. Dr. Furtado is a doctor of physical therapy. He's a board-certified neurological clinical specialist with the American Physical Therapy Association. Dr. Furtado specializes in vestibular rehabilitation and concussion and in managing the recovery of amputees and is recognized for his expertise for all of the above with the APTA. Dr. Furtado is currently an assistant professor at the University of Texas Medical Branch, also known as UTMB, where he serves as admissions chair and primary faculty for neuroscience and neurological clinical management. He also owns an outpatient private practice in Houston called AMPT Rehab, where he performs clinical practice and research in patients with vestibular dysfunction and neurological deficits. Dr. Furtado teaches entry-level students and clinicians in the area of concussion, and his portfolio of professional accolades includes various teaching and clinical awards with authorship of book chapters and numerous poster presentations and public speaking engagements. He presently lives in Houston, Texas with his wonderful wife, who is also a pediatric physical therapist, keeping it in the family, of course. And his education accolades began with his graduate university began at UConn with a Bachelor's of Science in Pre-Physical Therapy and a Master of Science in Physical Therapy in 2005. He later earned his Doctor of Physical Therapy from Boston University, where he was a practicing physical therapist. For 6 years, he worked as a staff physical therapist for TIRR Memorial Hermann Outpatient Rehabilitation in Houston, serving in leadership positions such as the Central Coordinator of Clinical Education and Senior Physical Therapist, creating the vestibular and balance programs in sports, concussion, and military veterans. Dr. Furtado, welcome to Concussion Corner.
Thank you so much for having me, Jess. I really appreciate the opportunity.
Yes, and thanks for waking up so early with me this morning to get this done.
I know. East Coast, Central Coast, they just don't match very well sometimes, but I'm glad to have you.
Just wait until it's when it's like Canada and Australia and West Coast, I get all sorts of confused.
That's right.
So what our listeners may not know is Michael is actually my co-faculty for the Evidence in Motion concussion management program that I created in 2015. And I have to say, he's one of the top 5 vestibular physical therapists in this world that I trust impeccably with concussion patients and educating across all professions from an interdisciplinary component. So, Michael, it's an awesome honor to have you on and kind of share your expertise with the world.
Yeah, I really appreciate having me. I really enjoy that role, and we have a lot of fun. We've been all across the country, so it's been a great time.
Yeah, and hopefully 2018 or 2019, it'll be an international venture. That's my fingers are crossed.
Yeah, me too.
So, essentially, episode 1, I really like to have folks just essentially meet you. Our listeners are all over the world and, they're either heading to work or listening at the gym or, listening in their home office and things like that. I'd love for you to kind of introduce yourself and really in a very Simon Sinek-esque, kind of touch on the why and how you kind of arrived, not only as vestibular physical therapist, because that holds its own, honor. And hard work and dedication, quite frankly, post-professionally. But really how you entreed into concussion and the care management of these patients in front of you.
Yeah, absolutely. It's nice now that I have experience where I can reflect back and say, oh, wow, this is why I really got to where I wanted to be. And this is why I wanted to be a physical therapist. And this is all these stars aligned in this way. But my passion for physical therapy sort of came from a personal injury, sports injury, very similar to many other physical therapists. And I decided to take on the profession. And from my graduate studies, I really focused on some sports management. I was able to do my rotations in Boston at the hospital for the Red Sox and really focused on ortho sports. But when I started to do my neuro rotations, I really found my passion in neuro rehab, and it sort of evolved from there. And I took my first job in Houston, which was, for me and my family, really very different. Texas is a different world almost from New England. And so for me to move, I said, I'll just go down there for 2 years and get some experience. Well, I'm almost 15 years there now, and I got a lot of experience, and I haven't come back yet. So I ended up starting in neurological rehab, and honestly, that watching the evolution from there really is fascinating, because I just had many opportunities to excel in working at TIR and at Memorial Hermann there. And from there, they said, hey, we're building a balanced program, and none of our current therapists have this expertise, and we need someone who has an interest and would like to take this on. And so I said, I do have an interest in this area, because at that point I'd been 2 years in and wanted to specialize in an area, and I really enjoyed balance and understood it well. And so went on to sort of get some continuing education and certification in the area of balance and vestibular rehab. And that really opened up quite a few doors and opportunities. And the timing started to get right with military, and how we were getting back from combat who were experiencing the traumatic brain injury, which was sort of an injury that was very new, which they quoted as mild at the time, of course. And that was really a way of beginning to start seeing this traumatic brain injury in that way. And so I started with this grant program that we had. It was a funded grant for seeing current military in our program. And so it was multidisciplinary. And my first looking at neuropsych and cognitive therapy, OT, PT, speech, all combined things. And then from there, the sports concussion talks started to really heat up and ramp up. And so that evolved into building a sports concussion program there. And the rest is history now. So now I moved on to teaching and taking on an academic position at UTMB, and I get to teach in this area of neurological rehab and concussion and vestibular. And so it's really a great opportunity. And so I get to really do that, and through those opportunities and meeting other professionals, just gained more exposure, experience, and really I'm very, very passionate in a specific area in concussion. Of course, the whole injury is so fascinating, but it's evolved into some research and clinical practice. And now I've gotten the ability to open up my own practice, which is great, because now I can sort of build a concussion program and really see it from the bottom up and really grow it in a way that I think is very meaningful. So we can do research, we can serve the community, and I think we can really have a really well-rounded approach in the management of these patients.
Indeed, and I'm just going to touch on a couple talking points from that fantastic intro. Essentially, when you were at TIR at Memorial Hermann, you were talking about, they were like, hey, we need to build a balance program, and I think consistent themes that I think our listeners will be learning from all of our guests here. Our first episode here was with Jeff Kutcher, and Dr. Kutcher's physician. He formed the first fellowship in sport neurology. And I think we're all been kind of around the early 2000, mid 2000, 2005, 2010, where all of this conversation went kind of from nothing to something. And and then there's still kind of like very few of us who are in the know, right? And I say that, in jest, but really it's fact. And how do we disseminate this information? So, I think for the listeners to really connect to that, concussion, rehabilitation, concussion, anything has really stemmed from different pieces coming together, whether it be legal, legislatively, vestibular-wise, we're looking at, hey, let's build a balance program. And then obviously it's stemming into concussion rehab and MTBI. And even, if we look at the literature with our ocular motor and our vision, a lot of that's coming from the MS world. We look at our sleep world as well. A lot of that also comes neurologically from MS, which we learned from, Dr. Katie Siengsakan on the podcast as well. So again, I think, it's just a wonderful injury just to kind of talk about like how everyone has honestly just come together. And, at this point, most folks that I engage with are really about helping each other. Like, hey, how can I help you help this patient population? So it's really been a wonderful community to get involved with.
Yeah, absolutely. Absolutely.
What were some issues that you had, when you were essentially going from building that balance program to, getting the military servicemen and women coming through your doors with concussion? What were some early difficulties in that creation?
Yeah, I think the main difficulties early on were primarily just understanding this injury and the gap, I think, that was in the published literature to what we were seeing in clinical practice. I found that to be the biggest challenge and barrier early on, because we understood at this point, there was still grading of concussion. There was still the theories of loss of consciousness is required for a concussion, but yet we were seeing patients with injuries that weren't consistent with that type of language. And so it was a barrier at first, especially. And for me, being a neurological therapist with a background in vestibular, it was easy for me to say, okay, I'm going to treat this patient from a neurological standpoint, and I'm going to treat balance from a neurological standpoint. But, the recognition of cervical treatment or exercise, that wasn't recognized back then. And so it was this anecdotal, I'm seeing this, the conversations are beginning, but there isn't this widely known published area. And the military especially were very complex in many facets, which really taught me a lot. And I'm glad I started with that patient population, because sometimes starting with the hardest is not that sports is not. They're both very difficult, but starting with such multi-layered complexities of even just being in the military brought in this whole complex issues with PTSD, and brought in issues with, certainly all of the, concussion and return to military. So very, very fascinating. And the timing has been really interesting.
Yeah, and a lot of this is really just for myself included, just really being in the right time and in the right place,
Yes.
Professionally. And obviously everyone, I think, is aware now that I have been a patient as well with a concussion. And it really is, quite something to kind of see the evolution, really the last 5 years. But, we can talk about the last 10 years and, certainly go back 100 when we were just talking about being, quote unquote, punch drunk. Now, with your experience and expertise with vestibular rehabilitation in medicine, as a physical therapist, I want to make sure I put this right. Historically, what have you seen in the last decade or so? And here's why. A lot of this is very Dunning-Kruger-esque, right? It's the unskilled and unaware clinician, and that becomes very dangerous. And we all take this oath to do no harm. But again, if we're unskilled and unaware that we are actually doing harm, hey, that's a whole different conversation. And we educate about that, that in the EIM program on evidence in motion. And whenever you and I speak all around the country, that, that's a very central tenet and speaking point. What have you found, really last 5 years? Let me know if you disagree on that. But last 5 years, we really just started talking about vestibular, the component of the concussive injury, and the ocular motor. And 2012 was the first year we internationally had a conversation about the cervical spine in our international consensus statement, and our fourth one from Zurich. So, what are your thoughts on how this really has evolved, really highlighting, obviously areas of physical therapy, but, the controversy of this injury in the last decade?
Yeah, absolutely. Your points are so well taken, because in the last 5 years, it's brought together the community of physical therapy in a way that we don't see in many other injuries. And many times the approach by specialization is by musculoskeletal approach or neuromuscular approach. And, this injury has required the communication of, even within our own profession, therapists to say, I have this understanding and I have this understanding, and let's bring it together. Because what we were seeing early on is, I certainly would approach my patients from a ocular motor vestibular standpoint, and some patients would get worse because that probably wasn't the target. I probably needed to target more cervical spine manual therapy, improving of posture before even doing vestibular. And I have found in more and more of my experience that I become less and less aggressive in vestibular think that component is very sensitive for patients. And
Michael, we lost you a little
really,
bit on we lost you just a little bit. Sorry to interrupt. I heard
no, that's okay.
I become a little less aggressive in vestibular, and then we kind of lost you for a little bit. Can you just go back?
Okay. Yeah, no problem. I was just saying that I have become a little less aggressive in my management of patients from a vestibular standpoint, in where I'm not saying I don't do vestibular. I, of course, include it. But traditionally with vestibular rehab, we do lots of things like habituation and adaptation, where it's increase the dizziness to improve the dizziness. And they're just, in concussion, it's not a passive, but it's just a little bit of a less. You have to be a little bit more careful in how you dose your response, in my experience, because of sort of setbacks and challenges. But at the time, probably patient from a whole perspective of cervical autonomic was not there. So now that I'm able to better utilize my whole well-rounded perspective and say, I think they need a little bit more exercise before they get to vestibular, or I think they need a little bit more ocular motor before they get to vestibular. My understanding has improved of that, and so therefore I believe my care has improved. But even in the vestibular realm, we're still trying to get this right with the dosage, the response, and it is still very individualistic based on patients. But I find that less is more with vestibular rehab these days.
Yeah, and for our listeners, I mean, these are like just golden tickets that, Michael is passing out, with, very valuable information. It's really important to understand from a patient perspective where your patients are coming from, because essentially when folks are going into vestibular treatment or physical therapy or rehab, they can essentially feel worse later on. So we have these transient symptoms, which is why if there is any sign of a symptom of concussion on a field, or if the worker is working on a line, you have to remove them from play or whatever environment they are that can put them in danger and others in danger. For example, driving if you're in a car crash. So essentially what happens to these patients is that they will use an environment that makes them feel good. So they will stay in an environment that may be low lit, that is quiet, doesn't have a lot of sensory neurological input that way, and they'll set themselves up for success, and then they'll quote unquote say, I feel fine. And we all know that in this concussion, I can feel Michael's smile here through the Skype call here. We all know that patients don't have the subjective language to express the what and how they feel when they have a brain injury or a vestibular injury or a migraine and all the things that encompass concussion. So it's very important to, connect to the heterogeneity of this injury and meet or exceed your patient's expectations that they may feel worse later on in the day or evening or even the next day. And quite frankly, especially I wave the flag to all the vestibular therapists out there internationally. And I'm like, you have to follow up with your patient if you think they may feel worse later that day or things like that. Because what happens is they become fearful of your treatment, and which is why the rapport and therapeutic alliance is so important, with this patient-provider relationship. Thoughts there, Michael?
Yeah, absolutely. I agree 100%. I was definitely smiling through the phone. I also, I do advocate, though. I do think quite a few patients, maybe more from the sports realm, because, the sports realm, obviously we have more of a return to sport goal. And so we have a lot of players like the parents and the coaches and the trainers. So, there tends to be a little bit more of pressure in that area. But I also do advocate that vestibular rehab is necessary, and we do have to adapt and train our patients beyond their limits. And I find that patients who can train more and do more vestibular rehab towards the times where they can tolerate it more, they do tend to, in anecdotal experience, have excellent outcomes and return symptom-free and do well. And so I definitely advocate for it. I do have some patients who just say, I feel like I'm at a good point right now. I probably didn't even have a really good working vestibular system before the concussion. So this is a good baseline for me. But I definitely advocate for going for those high level activities, because it's needed functionally. If we're going to be, running or recreationally or driving, we need the ability to utilize our vestibular system at very high frequency. So, I definitely say it's needed towards the end as well.
Right. And I really have to, not because, very Mrs. Doubtfire, I used to be one, right? That, I am a physical therapist, but I really have to value and advocate for the value of physical therapy here, and really specifically for 2 to 3-fold. One, we can touch our patients, which is so valuable in this world when most providers are barely doing a physical exam on folks. And I say that sincerely from a place of building other providers up, including ourselves as physical therapists, and this goes for all of healthcare. But again, when we have third-party payers dictating treatment, that is not okay. And we've kind of lost our way in healthcare a bit. And I really do hope that we'll start to shift in our career back to kind of the, old way of doing a comprehensive targeted physical examination on patients that walk through our doors. Yes. But, as Michael said, he's a little less aggressive on his vestibular. He is an expert in vestibular rehab, and he's aware of what he does and doesn't know. But the fact is that he can, touch the patient's upper cervical spine, where those vestibular and those cervical CO to C3 afferents are so valuable for our function and how we move, and from everything from migraine to vision to vestibular systems. He can prescribe exercise as a doctor of physical therapy, to kind of get that low-load cardiovascular training. Essentially, that creates BDNF, brain-derived neurotrophic factor, which is like Miracle-Gro for our hippocampus and our memories system. And it will help with mood and cognition and all of these things. So again, I know I am a physical therapist, obviously advocating for physical therapy, but the fact that we can have these conversations with someone like Michael, who has such an expertise in vestibular rehab, and the fact that he can do all of the above when the vestibular system may just not be ready to be treated that day as aggressively as was in his treatment plan or plan of care, he can diverge to autonomic, exercise training, reintegration, and focus on function, because essentially this injury is an injury of dysfunction in functional environments.
Yes, absolutely. Could not agree more.
Yeah. So anyway, that was my tangent there. So I know we have about 10 minutes left of this episode, Michael. I just wanted to highlight the vestibular system for our audience, just because really it is such a beautiful, thing when you think about it. Essentially, this little thing between our ears, essentially, really controls our whole entire environment and life, and it's just quite amazing for folks that go into the training that you do. As physical therapists, we have some entry-level training in the vestibular system, but I was just wondering if you can highlight a little bit of your training of what that looks like post-professionally and your journey there.
Yeah. So my entry-level education was very little, as many therapists had and have as well up to this point. And it was just included in a little bit of a course. But it started with taking some continuing ed courses. And what I found in the first couple of years is that not every continuing ed course is like the other. And there were some courses that I took that were probably not the great quality. And so then I sought out the quality from experiences. I always had a mentor as well at work, which I need to just also shout out to and also, discuss. But from a continuing ed standpoint in training, I think that going towards continuing education through the APTA, the American Physical Therapy Association, through Susan Herdman's Emory course, which is a vestibular rehabilitation competency course. That course is a week-long course, and you have practical competency-based examinations. So you feel much better coming from there with an experience of, I have, the ability to effectively use this knowledge that I just gained, effectively use it clinically, and then I can apply it day one. So I think that, there is a lot of alphabet soup in our profession. There is a lot of continuing ed, and it's not enough. You need to still go and apply it and use it in the clinic. And so I was blessed from the fact that I took the continuing education and the information that I've learned, and I had immediate ability to apply it. And I was in an environment in the clinic where I could try it with my patients, see how use my reflection in action, see how the response was to my patients, and then garner some themes that came from that to then be a recipient of the research, seek out research, teach about it, then create research ideas about it, all while being in an environment where I was mentored and had a team around me where I could say, what do you think about this? How do you think about that? And then training people around me too, so that then we could have a team together and collectively we could bounce ideas off of each other. I think that's so healthy to have and so necessary.
Indeed. And so spot on, really. I'm going to essentially set you up on a golf tee here, Michael, and I'm going to let the hit the ball off for for a good drive. So I just wanted to close out with kind of essentially what the vestibular system is and it's responsible for. So I'll provide some definition, and then I'm going to essentially have you kind of hit the ball off the tee and just kind of essentially let the listener know of like how and why this is so important for our concussion patients. Are you ready for that? Does that sound good?
Yeah, absolutely. I'll go for it.
All right.
Yes. Go ahead.
So we know that the vestibular system is essentially responsible for detecting linear and angular head movement and head position in space. So essentially what that is the head on body and body on head and how that interacts in space, and that's so important. And Michael will talk about that in a second. It also assists in gaze stabilization for the visual field. So this is very, very important to connect to, especially as ocular motor we'll highlight throughout Concussion Corner throughout the year. Maintaining balance and postural control, again, Concussion 101, and providing spatial orientation or perception of body movement. The vestibular system continually makes adjustments with the cooperation of interacting systems in response to movement. And the primary role of the vestibular system is to actually provide the central nervous system with information to regulate posture and to coordinate eye movement and head movements. So essentially the system represents our sense of balance or equilibrium and is often referred to as the sixth sense. So I was wondering if you can kind of, jump off with that sixth sense component and really why this, injury is so important for concussion rehab.
Yeah, absolutely. So with the link between in that vestibular system, like you were talking about, is the brainstem. So that brainstem link is really where the information sort of connects. So information comes in from that inner ear, and then that connection of the nuclei is really where a lot of information then communicates with other parts of our brain, communicates with our eyes, the centers of where our eyes move, communicates with our cortex, communicates with our cerebellum. And so the link is sort of that brainstem area because so much processing and integration of information is happening there. And so that in a concussion, when you have a traumatic head injury or head impact, and we have this neurons that are occurring, that link is sort of broken. And in my experience, many of the patients' complaints that come from the vestibular system is because of that link that is dysfunctional at the time. So there's information coming in that's usually normal, not in all patients, but in many of them, the information coming in is normal. It's just not processed normally with all of the other inputs that are coming in from the neck and from our balance centers and systems of balance. So when that information sort of gets jumbled and mixed, then we have the symptoms that are worse when trying to use that system. And so that refinement and integration piece then needs to be worked on. And I think that's the central tenet of vestibular rehab is sort of normalizing those pathways by giving people that paced, graded exposure to that stimulus in a very controlled way once they're able to process and integrate all of those systems. So yes, the ocular motor system, yes, the cervical system. And once they're able to integrate all of those pieces together to make the whole puzzle, then I think that link starts to work better. And I think an improvement in symptoms improve when that link improves its functioning.
Indeed, and I think what we see as as rehabilitative providers, as physical therapists, OT, neuropsych, speech, athletic training, and the whole gamut. I think we see this, it's tangible. We see this with cognitive processing, slowing down. And we see this with balance and postural issues. We see, oh, I don't know what's going on. I keep bumping into things, or I, keep hitting my head repetitively after I had this concussion. And folks, again, aren't able to, subjectively express, or objectively define, like, hey, this is happening because of, X, Y, and Z, which is why it's so important to have a provider that kind of knows what they're looking at, so they know what they're looking for. And clearly you fall into that. So, awesome to have you on, Michael. I try to keep everything to 30 minutes here. People really have meaningful attention for 20 to 30 minutes. So
exactly.
And I know we can talk for days. So we'll definitely have you on for episode 2, where we'll get into a little bit more clinical conversations, and just kind of hit it out of the park from there. Where is the best way for folks to reach out to you and kind of learn about you and so on and so forth? Social media, websites and things like that.
Yeah, absolutely. So thank you first and foremost for having me. I really appreciate it. I love the conversations you and I have. It's just they're so great and so meaningful. And so thank you for this opportunity to reach out. I love to communicate, whether it's on social media or through email on a patient case. I do this all day long. And so whichever way you want to reach out, I have Twitter. Officially on Twitter, my handle is MIFURTADPT. So me Furtado PT. And if you have a clinical question and you want to send a question about yourself or a patient, the email address, Michael, MICHAEL, at ampedrehab.com. And Amped Rehab is my clinic. And so there's a website for my clinic. And so if the beauty of now, it's not only do I get the opportunity to teach at the university, but I also get an opportunity to treat and see patients in my clinic. And so we have a concussion clinic, so it's great. So you can go to the clinic website as well. So either one way or the other, you can catch me in either of those platforms.
Awesome. And I'll have all those links in the show notes on how you can reach Michael. And I really, have to say that the people of Houston are so lucky to have, opening up in private practice. There is, a benefit of that. And I have to say is that, I don't know if you find this, Michael, but we really can spend more time with our patients
yes.
in a very unique way. And, I have to say that the folks down at Houston are so lucky to have you practicing down there at AMPT.
Well, thank you. I appreciate that.
Awesome. So we'll follow up in episode 2. But in the meantime, thanks so much for listening to the Concussion Corner podcast. And I look forward to having you on again.
Look forward to it. Thanks, Jess.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.